Welcome to this video. My name is Clea Makaran, and together with me is my task partner Andrea Makaraeg. And today, we will be discussing the pharmacology of cancer chemotherapeutic drugs. I will now begin to discuss a brief background about our topic for today. So, what is cancer? All of us probably already know what cancer is, hopefully. So it is a disease in which some cells in the body grow uncontrollably and invade tissues nearby or even spread systematically through blood and lymph systems. Cancer is the second leading cause of death. It is among the top 4 causes of death for all age groups except those younger than 1 year old. Among women, the most common cancers are those of the breast, lung, colorectal, and uterine, and among men are prostate, lung, colorectal, and urinary bladder cancer. Thanks to advancements in cancer drugs, deaths due to cancer have decreased to 13%. There are 3 modalities in treating cancer: surgery for solid cancers or tumors, radiation therapy, and drug therapy for disseminated cancers like leukemias, lymphomas, and metastasis. Drug therapy is also used to kill malignant cells that is left behind after surgeries or radiation treatments. We must also know that nitrogen mustards instigated the modern era of cancer therapy in 1942. Since then, we have made advancements in the field of chemotherapy. Nitrogen mustards were originally designed to kill warts that are even intended for warfare use, so it was originally a biological war weapon. There are 4 classes of anti-cancer drugs. First are cytotoxic agents, second are hormones and the hormone antagonists, third are biologic response modifiers, and fourth are targeted drugs. We must bear in mind that cytotoxic agents are the only ones classified as chemotherapeutic drugs, so we will mainly discuss cytotoxic agents in this video.
Characteristics of neoplastic cells. First is the persistent proliferation, invasive growth, formation and metastasis, and immortality. Persistent proliferation. Unlike normal cells, whose proliferation is carefully controlled, cancer cells undergo unrestrained growth and division. This capacity for persistent proliferation is the most distinguishing property of malignant cells. In the absence of intervention, cancerous tissues will continue to grow until they cause death. So, the example of the cell proliferation is discussed earlier is the rapid proliferation of the skin fibrillars to repair damage resulting from a cut or wound. Another striking example is provided by liver cells, which normally divide only rarely. Also, the persistent proliferation cancer cells that divided more rapidly than normal cells, and that this excessive rate of division was responsible for the abnormal growth patterns of cancerous tissues. Also, we know that this concept is not correct, but division of neoplastic cells is not necessarily rapid. Although other cancers are composed of cells and that divide slowly. Invasive growth. In the absence of malignancy, the various types of cells that compose a tissue remain segregated from one another. Cells of one type do not invade territory that belongs to cells of different type. So, and malignant cells are free of the constraints that inhibit invasive growth. As a result, cells of a solid tumor can penetrate adjacent tissues, thereby allowing the cancer to spread. So, the example of invasive cancer or invasive growth is a breast cancer. Breast cancer is typically start in either the milk ducts or the lobules that produce milk. Invasive breast cancer occurs when the cancer spreads into the other areas of breast surrounding tissues. Formation of metastases. Metastases are secondary tumors that appear at sites distant from the primary tumor. Metastases result from the unique ability of malignant cells to break away from their site of origin, migrate to other parts of the body or via the lymphatic and circulatory system, and then implant from a new tumor. So the example of formation of metastasis again is the metastatic cancer that has the same as the primary cancer. For example, is the breast cancer that spreads to the lung, and it's called metastatic breast cancer and not a lung cancer. Immortality. Unlike normal cells, which are programmed to differentiate and eventually die, cancer cells can undergo endless division. So, in other words, cancer cells, or the immortality, unlike the normal cells in our bodies, that can grow forever, and cancer cells' immortality leads to massive tumors, metastatic spread, and potentially reemergence. So, for the example of the immortality is the death or upon death that astral the body detach itself from the physical body and mourns in some region within time and space. Thus, even if the physical body decomposes, the astral body survives. This is type of the immortality most commonly presented in films and the literatures.
We will now discuss the etiology of cancer. So, due to either environmental factors like radiation, chemicals, or viruses, or due to genetic factors, there are 2 to 7 mutations on our somatic cells, which then changes the genome of our normal cells. It then leads to either the activation of growth-promoting oncogenes or the inactivation of the cancer suppressor genes. It will then lead to the expression of altered gene products and loss of regulatory gene products, and will finally lead to malignant neoplasm or cancer.
The growth fraction and its relationship to chemotherapy. The growth fraction of a tissue is a major determinant of its responsiveness to chemotherapy. First is the cell cycle. The cell cycle is the sequence of events that a cell goes through from one mitotic division to the next. And next is a growth fraction. In any tissue, some cells are going through the cell cycle, whereas others are resting in GO. The ratio of proliferation cells to GO cells is called growth fraction. A tissue with a large percentage of proliferation cells and few cells in GO has a high growth fraction. So, chemotherapeutic drugs are much more toxic to tissues that have a high growth fraction than to a tissue that have a low growth fraction.
Obstacles to successful chemotherapy. Why is there no perfect anti-cancer drug yet? So the first obstacle is its toxicity to normal cells. Dosage of anti-cancer drugs cannot exceed the amount that produces the maximally tolerated injury to cells. We can give large amount to cancer patients to produce cure, but it will most likely kill the patient since these drugs do not have selective toxicity. Meaning, unlike antibiotics who can distinguish between bacteria and normal cells by their cell walls, these drugs cannot distinguish between neoplastic and normal cells since both cells are very similar. Next, cure requires 100% cell kill. If there is even a single cancer cell left, the patient may experience remission. For most patients, 100% cell kill cannot be achieved. Why is that? So the first factor is the kinetics of drug-induced cell kill. Killing cancer cells follows first-order kinetics. At any given dose, a drug will kill a constant percentage of malignant cells regardless of how many actual cells are present. Meaning, from the beginning of the therapy until there are less malignant cells left, the dosage will be the same. The only problem is if the patient can handle the drug toxicities. Next is the minimal participation of the immune system. The immune system does not participate in killing cancer cells since they think that it is a normal cell. Additionally, some anti-cancer drugs are immunosuppressants, and some immune system cancers themselves, like lymphomas and leukemias, compromises the immune response. Third is the disappearance of symptoms before cancer cells are gone. Once the malignant cells are less than 1 billion, it becomes undetectable and symptoms disappear. Because of this, there is no objective indication to stop or continue the treatment. If treatment is stopped before all cancer cells are gone, patient may experience relapse.
Absence of really early detection. Early diagnosis of cancer focuses on detecting symptomatic patients as early as possible so they have the best chance for the absence treatment. So when cancer care is delayed or inaccessible, there is a lower chance of survival. Greater problems associated with treatment and higher cost of care. And even though truly early detections is largely impossible, every effort at relatively early detection should be made. The smaller a cancer is when treatment begins, the better the chances of a long-term survival, and hence even a cancer has 1 billion cells when it's detected, that's still far better than a gazillion. So the absence of truly early detections also has late detection and third detection. Next is the solid tumors respond poorly. Solid tumors have a low growth fraction and they are high percentage to GO cells and generally respond poorly to cytotoxic drugs. So the solid tumors, a word solid, they are low growth fraction and they respond poorly to the cytotoxic drugs, and not all solid tumors are equally unresponsive. As a rule, large tumors are even less responsive than a small one. So this difference occurs because as solid tumors increase in size, more of their cells leave the cell cycle and enter the GO.
Like in antibiotics, humans can experience cancer drug resistance. Mechanisms of resistance result from a change in DNA. These include reduced drug uptake, increased drug efflux, reduced drug activation, reduced target molecule sensitivity, and increased pair of drug-induced damage to DNA. Although drugs don't cause the mutations that render cells resistant, drugs do create selection pressure favoring the drug-resistant mutants. Meaning, if resistant cells are already present, the medication would kill the non-resistant drugs, leaving the drug-resistant cells, and the drug-resistant cells will increase. Combination therapy is usually the response for this. Next is the heterogeneity of tumor cells. Tumor cells are heterogeneous, meaning they are composed of dissimilar cells. These cells each have different response to medications. Last is the limited drug access to tumor cells. Tumor cells, depending on the location or size of the tumor, can be difficult to reach. For example, tumors in the central nervous system are hard to reach because of the blood-brain barrier.
Intermittent chemotherapy. The ultimate goal of the chemotherapy is to produce 100% kill of neoplastic cells while causing limited injury to normal tissues and especially the bone marrow and GI epithelium. Intermittent therapy is the primary technique for achieving these goals. In other words, intermittent chemotherapy has shown to reduce toxicity and improve quality of life. And also, the example of intermittent chemotherapy is the study that defined or stopping or changing maintenance therapy after initial cycles of chemotherapy and then restarting with any kind of therapy of any point in time. Combination chemotherapy. Patients are treated with 2 or more agents. It offers 3 advantages. First is the suppression of drug resistance, increased cancer cell kill, reduce injury to normal cells. So the suppression of drug resistance is antibiotic resistance and only use antibiotic when prescribed by a certified health professionals. And the antibiotics is never demand if your health worker says that you don't need that medication. Increase cancer cell kill. They may destroy healthy cells and organs, blocks their nutrient or oxygen supply, and allow waste products to build up. Reduce injury to normal cells. So in the living body, cell injury provokes a variety of vascular, inflammatory, and immune-mediated responses and in addition to disturbance of growth. These reactions not only extend beyond the injured cell to the organ or organismal level but also occur simultaneously in rapid succession.
Selection of the right drugs for cancer therapy is only one of the requirements for success. Those drugs must also be administered according to schedules that maximize beneficial effects. Dosing schedules are especially critical for drugs that act during a specific phase of the cell cycle. By using special techniques for drug delivery, we can increase drug access to tumors, thereby increasing cell kill and reducing systemic toxicity. There are different routes for cancer drug delivery. First is intra-arterial delivery. This is used for solid tumors. This concentrates the drug in the vicinity of tumor while minimizing toxicity to the rest of the body. Examples are carotid artery delivery for brain tumors and hepatic artery delivery for liver metastasis. Next is intrathecal delivery. Because many anti-cancer agents are unable to cross the blood-brain barrier, some are administered intrathecally. This is obviously for cancer in the central nervous system. There are also other specialized routes such as portal vein for liver metastasis, the bladder for bladder cancer, or implanting carmazine inside the wafer after brain surgery to kill remaining cancer cells.
Next is the major toxicities of chemotherapeutic drugs. The agents used for cancer chemotherapy constitute our most toxic group of medicine. So, this serious injury occurs most often to tissues with high growth fraction, and also we consider the more common toxicities of the cytotoxic anti-cancer drugs, along with steps that can be taken to minimize harm and discomfort. Bone marrow suppression. Bone marrow suppression is when fewer blood cells are made in the marrow. It can cause a decrease in red and white blood cells and platelets. Nearly all chemotherapy medicines cause a drop in blood cell counts. The drop in blood cells counts varies depending on which medicine are used for your child's treatment. So, what are the symptoms of bone marrow suppression? So, as we discussed, it decrease in red and white blood cells. You feel fever and chills and rush during the low of white blood cells, and in the red blood cells, the fatigue and extreme tiredness that doesn't get better with the rest, and paleness of skin, lips, and nail beds. Also in the platelets is you feel the easy bruising, bleeding, nosebleeds, gums or mouth, and tiny red spot on the skin. Also, the disease occur or in the bone marrow if you have a blood-related cancer like multiple myeloma. Your bone marrow may not be able to make enough blood cells, and this is called myelosuppression or bone marrow suppression. It can also be a side effect of some cancerous treatments like radiation chemotherapy drugs and steroids.
Next are digestive tract injuries. Since the growth fraction of the epithelial lining in the GI tract is high, it is sensitive to cytotoxic drugs. So, stomatitis and diarrhea are common. Stomatitis are mild sores or ulcers as seen in the picture above. Diarrhea can be caused by anti-cancer drugs by injuring the epithelial lining of the intestine and impair absorption of fluids and other nutrients. If injury to the GI tract is severe, it can lead to severe diseases.
Next is nausea and vomiting. So, nausea and vomiting are common sequel of cancer chemotherapy. These responses, which result in part of direct stimulation of the chemoreceptor trigger zone. It can be both immediate and dramatic and may persist for hours or even days. In some cases, discomfort is a great or a prompt refusal or further treatment.
Other severe toxicities are alopecia, reproductive toxicity, hyperuricemia or high uric acid, extravasation from vesicants when the drug makes contact with other tissues, unique toxicities like toxicities to the heart and kidney, and carcinogenesis, which is quite ironic. It happens when damage is dealt on DNA from anti-cancer drugs like alkylating agents. Is there hope for the future of anti-cancer cures? Scientists are still doing research to find a definite cure for cancer. In the meantime, we can take hope in the progress we achieved so far. Drugs such as trastuzumab Herceptin for breast cancer and imatinib Gleevec for chronic myeloid leukemia and GI stromal tumors are both highly effective and much less toxic than traditional chemotherapeutic agents. We will now discuss about cytotoxic agents and the 8 major subgroups under it. These agents are designed to kill rapidly dividing cancer cells, including normal cells, by interfering with their ability to divide and grow. The 8 subgroups of cytotoxic agents are alkylating agents, platinum compounds, antimetabolites, hypomethylating agents, anti-tumor antibiotics, mitotic inhibitors, topoisomerase inhibitors, and miscellaneous cytotoxic drugs. The mechanisms of cytotoxic actions are interference with DNA synthesis during cell division, cross-linking of DNA strands impairing DNA cell replication, inhibition of enzymes involved in DNA and RNA synthesis leading to DNA damage, disruption of microtubule function inhibiting proper chromosome separation during cell division, and generation of free radicals causing DNA damage and oxidative stress.
Cell cycle phase specificity. Cell cycle specific versus cell cycle non-specific. The definition of cell cycle specific is cell cycle agents acts on specific phases on point of the cell cycle. So the cell cycle specific is only act on the point or specific phases, while the cell cycle non-specific is acts on all phases of the cell cycles and including the resting phase. And specificity. The cell cycle specific has a high specificity, and the cell cycle non-specific has a low specificity. And the effects of killing of cell cycle specific is more effective in killing tumor cells and shorter period. So madali lang kill ng cell cycle specific ang tumor cells in a very short period, or speed time of the effectiveness. While the cell cycle non-specific less effective in killing tumor cells in a shorter period. So for the dosage, cell cycle specific has a small repetitive doses, while the cell cycle non-specific has a large doses given for the longer periods of time. For the action on the resting phase, the cell cycle specific does not act on the resting phase and the non-specific acts on the resting phase.
We will now discuss the dosage, handling, and administration of cytotoxic agents. The dosage and duration of treatment depends on the patient's age, weight, general health, and other factors. Direct contact with skin, eyes, and mucous membranes can result in local injury. Cytotoxic drugs should be prepared in closed systems and in areas that are separate from other drug preparations, just like what we see in the picture. The administration of cytotoxic drugs should be closely monitored by healthcare professionals. Personnel involved in the preparation, administration, and disposal of cytotoxic drugs should be properly trained and equipped with appropriate protective gear, and any spills or leaks should be cleaned up immediately during appropriate procedures and materials.
Alkylating agents. The first drug is the chlorambucil, a drug used to treat the chronic lymphocytic leukemia, Hodgkin lymphoma, and a certain type of non-Hodgkin lymphoma. It is also being studied in the treatment of other types of cancer, and the chlorambucil damages the cells DNA and may kill the cancer cells. So the adverse effect of the chlorambucil is bone marrow suppression, nausea, vomiting, and the hepatotoxicity. For the next drug of alkylating agents is the melphalan. Myclophenolate is a powerful vesicant and can cause severe local injury. Accordingly, for systemic therapy, the drug must be administered in 6. Caution must be exercised to avoid both extravasation and direct contact with the skin. Once in the bloodstream, myclophenolate undergoes rapid conversion to active metabolites, and the adverse effect of the melphalan is diarrhea, nausea and vomiting, alopecia, and stomatitis.
Next are platinum compounds. Platinum compounds are a class of chemotherapy drugs that contain the element platinum as their central component. They are administered via IV infusion. Platinum compounds are cell cycle phase non-specific. An example of a platinum compound is cisplatin. It is formerly available as platinol AQ. It kills cells primarily by forming cross-links between and within strands of DNA. Its indications are testicular and ovarian cancers and advanced bladder cancer. Its major toxicity is kidney damage, which can be minimized with diuretic therapy and imifostin. It is also highly emetogenic that it can induce nausea and vomiting just an hour after dosage. Its other adverse effects are peripheral neuropathy, mild to moderate bone marrow suppression, kidney damage, and ototoxicity. Next is carboplatin. Formerly available as paraplatin, carboplatin is an analog of cisplatin. Cell kill results from cross-linking of DNA. Its approved indications are initial and palliative therapy of advanced ovarian cancer. Anaphylactic reactions may occur minutes after dosing but can be managed with epinephrine, glucocorticoids, and antihistamines. Its adverse effects are similar to that of cisplatin, which are nausea and vomiting, nephrotoxicity, neurotoxicity, and hearing loss.
Antimetabolites. Antimetabolites are structural analogs of important natural metabolites because they resemble natural metabolites, and these drugs are able to disrupt critical metabolic processes. And there are 3 classes of antimetabolites. First is the folic acid analogs, pyrimidine, and the purine analogs. Antimetabolites are chemotherapy drugs that prevent cancer cells from making more cancer cells, and they trick cancer cells into using the drug instead of the molecules it needs to make the genetic material to replicate, or DNA. Antimetabolites treat the breast cancer, colorectal cancer, and the lung cancers, and among others. So the drug in the folic acid analogs is the methotrexate. Methotrexate belongs to a class of drugs known as antimetabolites. cures cancer by reducing cancer cells proliferation and cures psoriasis by inhibiting the proliferation of skin cells, preventing the formation of scales, and used to treat the rheumatoid arthritis and suppressing immune system activity. So the adverse effect of the methotrexate is drowsiness, hair loss, reddened eyes, and decreased appetite. In pyrimidine analogs, the drugs is the fluorouracil. Fluorouracil or the Advurcil is fluorinated derivative of uracil. The drug is employed extensively to treat the solid tumors. Fluorouracil is an anti-neoplastic antimetabolite, and antimetabolites masquerade as purine or pyrimidine, which become the building blocks of DNA. And the adverse effect of the fluorouracil is the loss of appetite, nausea, vision changes, dry and cracked skin. For the purine analogs, the drugs is the mercaptopurine. Mercaptopurine is a medication used in the management and treatment of acute lymphoblastic leukemia. It is in the class of medication known as purine antagonist. And the adverse effect of the mercaptopurine is the loss of appetite, nausea and vomiting, and the hair loss.
Next, cytotoxic agents or hypomethylating agents. They inhibit DNA methyltransferase, an enzyme that puts methyl groups into DNA components. They can slow down the progression of MDS and AML, and in some cases, even induce remission. They are administered via subcutaneous injection or IV infusion. First drug under this group is azacitidine. Also known as Vidaza or Onureg, it is a pyrimidine nucleoside analog used to treat myelodysplastic syndrome, a disease which can progress to acute myelogenous leukemia. It is a treatment for people who can't have high-dose treatment with a stem cell transplant or bone marrow transplant. It is administered via subcutaneous or intravenous injection. Its adverse effects are myelosuppression, nausea and vomiting, and CNS depression. Next drug is decitabine. Like azacitidine, it is used to treat myelodysplastic syndrome. It is administered via IV infusion. Adverse effects are myelosuppression, nausea and vomiting, and flu-like symptoms.
Anti-tumor antibiotics. Anti-tumor antibiotics are cytotoxic medicines that were initially isolated. Streptomyces cultures were used. They are divided into two categories, and there are atracyclines and non-atracyclines. Anti-tumor antibiotics are used only to treat the cancer. They are not used to treat infections. All of these drugs is injured to cells through the direct interactions with DNA. Because of poor GI absorption, they are all administered parenterally, almost always in IV. The drugs that belongs to anthracyclines are the doxorubicin and the conventional. Doxorubicin or the adriamycin belongs to the anthracycline family and is widely used to treat the broad spectrum of malignancies such as breast, lung, and bladder cancer and the lymphoma. Conventional chemotherapy means the treatment of disease, specifically cancer, by the use of chemical substances. And the adverse effect of the doxorubicin and the conventional or the nausea and vomiting, fatigue, alopecia, and oral sores. The drugs that belong to the non-anthracyclines is the dactinomycin. Non-anthracyclines do not injure the heart. However, these drugs do not have serious toxicities of their own. A type of antibiotic that comes from a certain types of Streptomyces bacteria. Anthracyclines are used to treat the many types of cancer, damage the DNA in the cancer cells, causing them to die. Daunorubicin and the doxorubicin and the eperamycin are the anthracyclines. And the adverse effect of the dactinomycin are the severe immunosuppression, nausea and vomiting, bone marrow suppression, and the hair loss.
Next are mitotic inhibitors. Just like their name suggests, they are drugs that act during M phase to prevent cell division. There are two major groups of these drugs, vinca alkaloids and taxanes. Vincristine is a vinca alkaloid used to treat Hodgkin's and non-Hodgkin's lymphomas, acute lymphocytic leukemia, Wilms tumor, rhabdomyosarcoma, Kaposi sarcoma, breast cancer, and bladder cancer. It is administered via IV injection and causes less bone marrow suppression compared to other cytotoxic drugs. Its adverse effects are peripheral neuropathy, decreased reflexes, weakness, paresthesias, and sensory loss. Next drug is paclitaxel under taxanes. It acts during late G and M phases to promote formation of stable microtubules, thereby inhibiting cell division and producing apoptosis. It is used in the treatment of Kaposi sarcoma and cancer of the lung, ovarian, and breast, administered via IV infusion. Its adverse effects are hypotension, dyspnea, angioedema, urticaria, neutropenia, muscle and joint pain, myocardial infarction, reversible alopecia, and GI reactions such as nausea, vomiting, and diarrhea mucositis.
Topoisomerase inhibitors. Topoisomerase inhibitors block the ligation step of the cell cycle, which generates DNA single and the double-stranded breaks, leading to the apoptotic cell death. And the topoisomerase 1 inhibitors include irinotecan, topotecan, and the camptothecin. And the topoisomerase 2 is the inhibitors include etoposide and the deoxyribonucleic and the eperamycin. Topotecan drug. Topotecan drug is used to treat a small cell lung cancer, or a type of cancer that begins in the lungs, that was successfully treated with a different chemotherapy medication, but has returned no sooner than 45 days after the last dose of the first chemotherapy medication was taken. And the adverse effect of the topotecan is the blackitary stool, blood in the urine or stools, body aches or pain, and the chest pain. Next is the irinotecan drug. Irinotecan is a type of chemotherapy. It is also known by its brand name CAMP2. It is a treatment for cancer that started in the bowel or the bowel cancer. This includes the colon and the back passage or the rectum. And the adverse effect of the irinotecan is the hoarseness, itching, trouble breathing, and fever.
Here we have asparaginase, and it is an enzyme that by converting asparagine to aspartic acid, the drug deprives cells of asparagine needed to synthesize proteins, and it acts during G1. It is used for acute lymphocytic leukemia and administered via parenteral IV and IM. Adverse effects are nausea and vomiting, fatal anaphylaxis, and coagulation deficiencies. And another miscellaneous cytotoxic drug is altretamin. It is indicated for palliative therapy of persistent or recurrent ovarian cancer. It is absorbed well following oral dosing. Its adverse effects are nausea and vomiting, bone marrow suppression, peripheral sensory neuropathy, and central neurotoxicity. And now, we have non-cytotoxic agents. And again, we must remember that they are not considered as chemotherapeutic drugs, just anti-cancer drugs. It consists of two large groups of drugs, hormonal agents and targeted drugs. They lack phase specificity and lacks the serious toxicities associated with cytotoxic agents, including bone marrow suppression, stomatitis, alopecia, severe nausea and vomiting. But despite that, some are identified as hazardous by the National Institute for Occupational Safety and Health.
Hormonal agents. Hormonal agents are widely used in curative and palliative treatment of hormone-dependent tumors. Hormonal therapies can be used for acne in young women. Combination oral contraceptives and the spironolactone are the main agents employed. In both cases, benefit derived from decreasing the androgen activity, leading to decrease the production of C2. So the hormonal agents has types. First is the oral contraceptives and the spironolactone. And the oral contraceptives is the 4 combination OCS, estradiol, ortho, tricycline, and Diaz, and the YAZ are approved for managing acne in women. Treatment is limited for the females at least 15 years old who want contraception, have reached menarche, and have not responded to total topical drugs. Spironolactone. It is the aldactone that blocks a variety of steroid receptors.
Lastly, we have targeted drugs. They are antibodies that bind to specific antigens on tumor cells. Others are small molecules that inhibit intracellular enzymes. The hope is that these drugs will be more selective than hormones and cytotoxic anti-cancer drugs, and hence will be able to destroy cancer cells while leaving normal cells untouched. There are 7 subgroups under targeted drugs. First one are tyrosine kinase inhibitors or TKIs. These drugs block specific enzymes called tyrosine kinases, which are involved in cell signaling pathways. Examples include imatinib, erlotinib, and sunitinib. Next are monoclonal antibodies. These are antibodies that specifically bind to target molecules or receptors. They can trigger immune responses against targeted cells, block receptor signaling, or deliver drugs or toxins. Examples include trastuzumab, rituximab, and bevacizumab. Hormone antagonists and inhibitors are drugs that interfere with the action or production of hormones that contribute to the development or growth of diseases. Examples include tamoxifen, an estrogen receptor antagonist used in breast cancer, and finasteride, a 5-alpha reductase inhibitor used in benign prostatic hyperplasia. Immune checkpoint inhibitors are drugs that block the inhibitory signals in immune cells, allowing for enhanced immune responses against cancer cells. Examples include pembrolizumab and nivolumab. They can be used for lung, cervical, neck and head cancer, and Hodgkin's lymphoma. Next are proteasome inhibitors. These drugs inhibit the activity of proteasomes, cellular complexes responsible for protein degradation. Examples include bortezomib and carfilzomib used in multiple myeloma. Angiogenesis inhibitors. These drugs interfere with the process of angiogenesis, the formation of new blood vessels. They help to deprive tumors of blood supply needed for growth. Examples include bevacizumab and aflibercept. It is used for many types of cancer. Lastly, we have epigenetic modifiers. These drugs alter the epigenetic regulation of gene expression, impacting disease processes. Examples include azacitidine and azacitidine, and they are used in myelodysplastic syndromes.
Conclusion: in the cancer, chemotherapy drugs are medication used to treat the cancer by inhibiting the growth and the division of the cancer cells. There are 8 major groups of cytotoxic agents versus the alkylating agents, platinum compounds, antimetabolites, hypomethylating agents, anti-tumor antibiotic, mitotic inhibitors, topoisomerase inhibitors, and the miscellaneous cytotoxic drugs. And the other non-cytotoxic drugs include hormonal agents and targeted drugs.
Thank you so much for listening. We really hope that you learned something about chemotherapeutic drugs. And don't forget to check other videos on this channel. Goodbye!